All right. The second thing, guys, anybody has a question, please raise his hand so we can answer the question. The third thing is that it doesn't have to be my fellow to read the question or answer the question. Anyone want to answer the question, please raise his hand and he can answer the question. The other things, it's normal not to know the answers because otherwise we'll not be doing this review. So don't be shy that you don't know the answer or you answer wrong. This is normal. And again, the reason why we're having this review, so you can answer wrong, so we can correct you. So feel free to answer, please, guys. The more interaction will be more benefit. And again, there is no bad question. Any question doesn't matter how it is. It's to be beneficial for everyone. And the third thing, nobody know who's talking. So don't be shy because nobody know who you are. Just ask your question. And again, please, if you feel that you want to answer any question, just raise up your hand and you can ask questions. All right, so we're going to start with, let me see if I can share my desktop. Sorry, let me see what it is. Oops, what happened? Screen sharing, here we are. All right, can you see the screen, guys? So this is a case scenario. And
here, Dr. Samer.
Muhammad, you want to start?
Yes, sure, Doctor.
And we'll see. Be also.
Hi, everyone. Good evening. Muhammad Dahman, I'll start. A 59-year-old man presented with an abdominal aortic aneurysm discovered on double scan examination of the abdomen. The AAA was 56 millimeter large with slightly conic infrarenal neck and aneurysmal right common iliac artery. The patient was otherwise asymptomatic with no abdominal or back pain. His past medical history was significant for hypertension controlled by therapy, non-insulin dependent diabetes diagnosed 5 years previously, and smoking history of 30 packs per year. He did not have any history of myocardial infarction, angina pectoris, or intermittent claudication. He could still play 18 holes of golf and run once a week without difficulties. His family history revealed that his father died of aortic aneurysm rupture. He had 66-year-old brother without apparent health problem. On examination, the patient was slightly overweight. There was no palpable abdominal mass, and his past surgical history was only relevant for groin hernia, repaired in the mid-30s. A CT scan was performed. Routine blood tests were normal, as well as ECG and chest X-ray.
Okay, so what we have here, Muhammad, we have guys 59 and
yeah.
You know, middle age.
Middle age with 56 abdominal aortic aneurysm with slightly right aorto-iliac aneurysm, basically. And he's asymptomatic. He appears to be fit. And yeah, and we'll see the
his risk factor is he has diabetes.
Family history, being a male, being above 50 years old, with family history, smoking and hypertension.
Okay, this is a risk factor, but in general, he's in good shape. He said he's
yeah, he's in a good shape.
Look, is there any difficulties and all the things? Okay.
Yeah.
So let's see what's the first question. Okay, see what they said here. Let's go with the first one.
So the AAA of this patient was found and by systemic screening. In which group of population is duplex scan screening is for AAA justified?
Okay, first, I mean, we have multiple answers. It's not like one answer, so it can be more than one. So we're going to go through which one in detail. So now they ask about duplex scanning screening. And again, this is a very common question in the exam, guys. So really, you have to know when you do duplex scanning because it's cost effective, you know. So it's very common to see in the exam, they always ask about duplex scan, how often you do it, when you do it, what's the risk factor, and all the things, okay? So let's start with the first one, uncomplicated hypertension patient.
I know you can do it, but it's not in the guideline yet.
Okay, so uncomplicated hypertension patient doesn't need screening, correct? Okay.
Yeah.
So, well, let's say before we go, what patient do you think you need screening in general? We're not talking about this one.
In our,
screening?
I think in our guideline or what we are doing now, for any patient with family history of aneurysmal disease that is ages 50 and above.
If it's, you think it was a family, so you say it's family
history and being male with risk factor.
Well, let's take one by one.
Yeah.
If he has a family history, let's say somebody has family history.
Yeah.
When should we start screening? What age?
50.
55.
Around 50. Okay? Yeah, 55. Yeah.
55. Okay. So if he has a family history, you have to start early 55. There's no family history. When we start? What age we start?
70.
No, 70 is too much. 65.
65.
So, 65. So any male, so if we have to do any study, if we have to run any, why is it important? Because if we decide, let's say we're going to screen in Saudi Arabia, okay, the people, then he has to be men and above 65, you know. We start one day's screening here, we start in 60 because this is, you know, Western data. So we don't know how Saudi, we say, let's start in 60. Because we don't know, maybe Saudi is different, so we don't know. And we did that, and we didn't find major difference really. It was, incidence was very low. But if you go with the European data, it has to be men, 65 and above. Or what about female? What age? The same, but has to be smoker. If female is not smoker, then you don't have to start the screening, okay? Because, you know, it's more common in male. So male 65 or female and smoking 65 and above. If patient has a family history, then you start earlier at age of 55, okay?
Okay.
So let's go with this first one. So uncomplicated hypertension patient is not a risk factor, correct?
Yeah.
What about second one? Patient with family history.
Yeah, this is meant to be right.
Yeah. Correct. What about patient with smoking history? Yes, but there is also AAA. We're talking about in general, right? So we're not talking about age, no, in general. Patient is smoking. This is a risk factor for aneurysm, right?
Yeah.
A patient who smoke, then we have to do, but of course we do it after age 65. But he didn't put an age, he's talking in general. Is a smoking risk factor for AAA or not?
Yes.
It is. So patient with a smoking history, he need to do a duplex ultrasound. It's justified. Okay, so if you're going to do like put a protocol, you put patient first, 65 and above men, smoking, female smoking, aneurysmal history or family history also we have to screen them, okay?
Yeah.
So let's see what else. Let me give us more. Yeah. What about peripheral vascular disease?
I don't know if it's justified for AAA, it's justified for ultrasound, but AAA, no.
Do you think that is increase patients with AAA?
No.
No, it is one risk factor because vascular occlusive disease also risk factor for aneurysm because the same risk factor for disease are for, you know, if you look at risk factor, same, it's hypertension, smoking, you know, hyperlipidemia, all of them are this one. So risk factor really, the age is important because the older is higher chance of aneurysm. So the age is one. Smoking is good. Vascular disease or in general atherosclerotic disease also is a risk factors. Again, hypertension is a risk factors. So peripheral vascular disease, it is, but indirectly that it is atherosclerotic disease in general, you know. So patients with peripheral vascular disease, yes, I think should be a risk factors. What next? Obese patient is vascular risk factor. Does obesity increase your chance of aneurysm?
I don't think, no. It's
No,
not,
so should not do that. All men start at age 50.
Not all,
Not all of them at age 50. Should be at 65, right? No, we said all men start age 65, we need a screening. And all female at 65 and smoking should have screening. Any people with family history at age 55 should be screening, okay? Anybody with a smoking history should be screened. Hypertension, hyperlipidemia, coronary artery disease, peripheral vascular disease, age, you know, they should be screened, you know. Any question, guys, about this one? Or Ali, you want to add anything, guys? Okay, nothing controversial, just a data here. But again, this is, guys, important for the exam. I'm sure always you're going to get a question about this screening, you know. So let's go question 2. Let's get somebody else. Who's here? Ahmed, you want to take number 2?
Yes, please.
Okay.
Without treatment, this patient is at risk of rupture. Among the following factors, which one has been proved to be the most associated with increased risk of rupture? Generally speaking, the diameter.
Correct. But we have 2 more risk factors. This is multiple, not one.
Yes, all right.
So let's start one by one. So diameter more than 60. It's
Usually more than 55 mm.
Correct. Next one, associated with hypogastric aneurysm. Does it increase rupture? If you have
iliac aneurysm as well?
Hypogastric, internal iliac.
Yeah, internal iliac. Not sure if having it in another aneurysm in the iliac would increase the risk.
Risk of rupture, no. So the answer is no. No, it's not no correlationship. You can find it, but with that, like if you have an hypogastric artery aneurysm, with aortic aneurysm will not change your criteria. Not say, oh, it's on high risk of rupture. So it's not.
Yeah.
It's not a risk factors. You know, it's a risk factor for something else. We can talk about later on, but not for ruptures. Okay. What about diabetes?
Being diabetic is a risk factor. Hypertension is it? No, not really. Diabetes per se?
Mm-hmm.
No, it isn't.
It's not. And even we think that sometimes diabetic could be a protective.
It's right for atherosclerosis, but not for aneurysm.
We're talking about rupture, remember? Okay. Of rupture, not talking about the instance of aneurysm, talking about instance of ruptures. Like a patient comes with a AAA and he has diabetes. You say, oh, it's high risk of rupture, we have to do it earlier. No. But if he comes like large aneurysm, like 9 or 10, it's high, then you say, oh, we have to do it as soon as possible because of the risk of rupture, right?
Yes, true.
So this one, yes. Diabetes is not, again, some people even think that diabetes could be protective. The reason why we don't see much aneurysm in Saudi Arabia because high incidence of diabetes.
Yes.
And we think it's not the diabetes, we think it's a metformin. Yeah, sorry, glucophage. We think it's a glucophage is the reason why, because most people take a glucophage. Many studies showed that glucophage, it decreases the size of the aneurysms. And even some people now, they think, but the paper is not very strong, to start giving glucophage for people with aneurysm to stabilize the sac and prevent increased enlarging of the aneurysm. But again, we don't have strong data to get to this recommendation yet. Lower limb occlusive disease, nothing to do with the ruptures.
Nothing, yeah. Smoking is one of them. And so is COPD, yes.
And COPD, yes. It's a pulmonary lung function, and smoking is an increased risk of rupture. So patient comes with COPD and aneurysm, you have to think about to do them. Don't wait for a long time. Large aneurysm, smoking has to quit smoking because otherwise the aneurysm continue to increase and may ruptures. So these all risk factors, Some people, they think the female gender also is a risk factors. And the reason why,
they have a rupture on smaller diameters even.
Correct. So small diameters, the reason why female ruptures aneurysm, you have to be more aggressive with them also. The female also could be a risk factor for rupture aneurysm, okay?
Okay.
All right. It's not bad so far. Let's go to number 3. Anybody question, please, guys? I want to be more interactive than just me talk, you know, or any question. Either you can put it in the group or you can ask questions, you know. Who want to ask the third question, number 3? Anybody, guys, want to answer?
Yes, Dr. Samer.
Who?
I can. I am.
Oh, give chance for the people.
We have here like
Oh,
people I
Haitham?
know.
22%.
Yahya al-Malki is.
Okay, yeah, go ahead.
He's coming.
Don't be shy, guys.
Yeah, Muhammad al-Dosri also is coming to us in January.
Hello?
I don't know if they can talk or
Yes, I can talk, but I'm in the cafe, so I don't want to be noise voices. Okay, hi, my name is Dr. Hamid Dosir. I'm a vascular from King Saud University. So thank you, Dr. Samer, for this lecture. I will start with the question 3. With the imaging you have been provided with, are there any reason of performing arteriogram?
We didn't see the images. We don't see the images. Let me show the image. They put, I think, the image here. Let me see here. Can you see the image, or I have to put it?
No, I can't see.
You cannot see, right? Okay, let me see. I have to share my screen. Sorry. Here we are. So this is the image here. So you can see the aneurysm here. You see it now?
Yes, I see.
Okay. So this is the liver of the renal. This is here. It's the liver of the renal artery. So you have the neck here. Looks dilated. Disease, neck. This is aneurysm here. Down, you see the neck is here. This is the renal artery. This just give us these 2 images, and they said CAT scan aortic aneurysm was right cone iliac artery aneurysm. Okay, so not much really. So they give a CT angiogram. So the question now, we go back to here. So can you read the question now?
Sorry, I can't see the screen. Just give me a second.
Okay, let me see. Sorry. Why is not? What happened now? Yeah, this technology sometimes.
now is better, doctor.
Yeah, now, okay. So with the image you have provided, reason to do you need to do an angiogram?
Yes, and you mean an angiogram for diagnosis or for treatment?
Let's see what they said. First, they said no need, CT scan is sufficient. Okay. You think that CT angiogram for aortic aneurysm is enough, or you have to do an angiogram?
Yes, I think it's enough.
It's enough, correct. So AAA is enough. I mean, all we do it is more than enough. We used to do an angiogram before, a long time ago, but now the quality of CT scan becomes so good, really we have to do an angiogram. So let's go with a P.
An angiogram is mandatory to facilitate the planning of surgical procedure in case of difficult anatomy.
This is correct or wrong? This is wrong.
No,
go ahead an angiogram, because CAT scan give you all the information, right?
Yes.
I don't think angiogram can add anything. Like CAT scan, you can see better, you can see the reconstruction, you can see AP laterals, you know. You can see the wall of the aneurysm, the thickening, you know, the clot. So really, CT can give us much information. So I don't think it can, and the planning, it doesn't do blacks. The planning, CT angiogram is better. You can see the size, you see the clot. You don't see it in angiogram. So angiogram will not help in this one, no. Let's go to the C.
Angiogram will be needed in case of endovascular treatment. And during the OR, yes, it's endovascular procedure, but not for planning endovascular. CT enough.
Correct. So we need for Professor CT is enough. Let's say angioplasty. Okay, let's go to the last one.
Angiography is necessary to rule out any asymptomatic associated visceral artery stenosis. No, CT enough. CT angio, abdomen is enough.
Okay. So let's go back. You're right. So all is wrong. CT is enough. We don't need anything. We can have a planning. This is a real life. That's what we do. We get a CT angiogram. We do our planning. That's more than enough, right? So let's see when we do an angiogram. When you really need an angiogram before surgery, we need only for therapeutic. When you think we need therapeutic for what? If we have any stenosis somewhere, like you have renal artery stenosis, right? You may go and stent it. If you have SMA stenosis or celiac artery stenosis and patient symptomatic, it's better to do it. My question now, let's say patient has an SMA stenosis and AAA, and he has an angina, abdominal angina and AAA. So you're going to do a surgery on him. Do you do an angiogram before and stent for the SMA and then you proceed with a AAA repair, or you do AAA repair and bypass to the SMA? This is very common scenario. I mean, not common scenario, but could happen.
That is an open or endovascular, Dr. Samer?
Open. You're doing an open. Let's say you do an open. Because endovascular, it's very, of course, you can do stent and EVA, right?
Yes.
But let's say you can do an open repair aneurysm, and you have an celiac or SMA stenosis and patient symptomatic. He has like abdominal angina. So
we need at least one of them.
Sorry?
We need at least one of them.
What I'm saying is already has one of them and it's symptomatic. I'm not going to argue about indication. I'm saying he has like celiac occlusion, SMA stenosis, IMA is occluded. So he has symptoms, okay? So we need to treat SMA. But my question, how we treat it? Should I do infrarenal aortic aneurysm repair and do bypass with SMA? Or go first do angioplasty to SMA and stent, and then later on go and do infrarenal aortic aneurysm open repair?
Concomitantly with island implantation.
We can do both way, but which one is better? Of course, I mean, if you do either of them, I'm not going to say you're wrong. I mean, if I do an open repair and do bypass, I'm not going to say you're doing wrong, right? I mean, both options are open, and both are correct. But which one is better is stenting first. The reason why, because if you do a bypass, you increase more morbidity and mortality. The surgery becomes more complicated, you see? So if you have something doing the vascular, because you have to do your surgery as low morbidity mortality. The more you prolong your AAA surgery, increase your morbidity, increase your mortality, you know? The reason why the shorter you make it will be safer for the patients. So if something you can tackle with endovascular, then yes. So if you have an SMA stenosis, you go JZR balloon stented, and then you go do AAA, it will be better than you can do bypass. But doesn't mean that if you do bypass is wrong, you can do that, you know. Some people, they can argue about patency, which one is better. I don't think it's a major difference, the patency, you know. But no question that doing infrarenal aortic aneurysm with a SMA bypass or celiac bypass, it will prolong your surgery. And the longer patient under anesthesia, under, you know, open, abdomen is open, you see you increase your morbidity and mortality. Okay? I don't know if Dr. Ali has, Isam also here. I don't know if guys, you agree with me. Isam here, raise his hand. Go ahead, Isam.
Hi guys, I'm out and about, but I just thought I'd pop in and say hello.
Yes.
I think you're absolutely right. It depends on what's bringing you to the OR. Is it the SMA or is it the aneurysm?
Let's say
if it's the SMA, then I disagree. I do think a surgical bypass is more durable than a stent or a balloon angioplasty. But if the patient is frail, then yes, maybe you can stent it or balloon it and then do your open aneurysm. I tend to drop a graft on the SMA with the aneurysm if I'm going to do an open repair. But you're right, it does increase mortality. It takes you from the 3% up to the 5 or 6% band for mortality. That's
so you have to
my
patient. Yeah, I agree with that. Any comment about the previous question, Isam? If you listen,
I agree with Samer, Isam. I agree with Samer. It's better to do a stent before then. You can proceed with the AAA. And even if you have a stenosis, a renal artery stenosis, so you can proceed for PTA before then, you can proceed for the surgery if you have to make surgery.
Okay, I think, as I said, I mean, for the junior, I mean, both are correct. I mean, just doing which one is better. I think you have to individualize your patient, looking at the patient, how fragile, how can take. Of course, the younger the patient will be more aggressive. But if you look at the data, as Sam said, that of course, anything you do extra increase your morbidity and mortality. So you have to take in consideration that. So you have to look at the patient and look at the risk and you make your decision. But both way, I think is acceptable. Either you go in the vascular, but recommendation that, again, I mean, is to do intervention first and do bypass to decrease time of surgery. But if you do them both, it's not wrong, I think.
Yeah, I think in terms of the juniors in the exam, I mean, certainly in the FRCS, there'll be many scenarios like this where there are multiple very credible options. What we require from the candidate is that they have an opinion and that they are able to defend that opinion based on some evidence. So, you know, if you can defend whatever you say, then you're fine. But if you don't, if you're not able to appraise the risks and benefits of both options, then you get into trouble.
100% correct, Isam. And this is the most important, guys, before in the exam. Whatever you do, it's okay. But as far as your defense, even if you do surgery, I don't do. Like patient come with aortic occlusion, you know, and I want to do aortic bypass. You know, you tell me, you give me an answer, no, I want to axillo bypass. I have no problem. I may not do it, but you have to tell me why. And you have to convince me why, you know. So as far as you have a reason why you do your approach, I think nothing wrong. I mean, everyone did different approach, but they have to defense it with the data and with the numbers. All right, we can go to next question now. Number 4. Hamad, you want to go back?
Yeah, just the previous point about when you do angiography first before an EVAR, if you have access problems that you want to dilate before you come in, and if you need to coil one of if you're going to coil one of the hypogastrics, many people do that 2 weeks before they do the EVAR, especially if they're going to potentially take out the other hypogastric. So that's an indication for angiography prior to EVAR.
That's correct, but not diagnostic. I think Isam, they mentioned this question, diagnostic angiogram, but I agree. If you're going to do therapeutic, yes.
Yeah, there's no role, there's no need for diagnostic with modern CT. Yeah, yeah.
We used to do it before when we started doing an EVAR long time ago. We used to do an angiogram for sizing and everything, but now you don't need it really. Yeah. But I agree, you're right. If you want to coil the internal, or now some people, they advocate to coil the lumbars before you go to prevent type 2 endoleak, or you have accessory renal, you know, whatever you have to do, always try to do in stage. I think is better. You decrease time of the surgery and contrast overload. All right, can go to question 4. I'm happy Isam here for this one because Isam is expert with cardiac risk evaluations. So let's get to question number 4, and Isam will take this one. Go ahead, Muhammad.
Yeah, to assess the operative cardiac risk, would you need any further tests in our patient? So this patient first, he has coronary artery, he has hypertension, diabetes. But he has a very active. He play golf. He's very active. Yeah, he can run and no history of MI. No history of MI, no angina, nothing. So no cardiac history. So the only risk factor, he has diabetes and hypertension. Yes. Okay. So now the question: what else we need to do? Do we need to do anything else, or that is enough? Does it make a difference? Let's start one by one. The first one. So A, non-ECG is sufficient. Okay. B, cardiac scintigraphy. C, cardiac echography. D, cardiac echography with dobutamine test. E, coronary angiography. Yeah. Go ahead. We discussed this like 1 week ago, me and you, and it showed that echo has no role in assessing the risk factor for open aortic aneurysm. And for this kind of patient, which shows good cardiopulmonary function, I think non-ECG is sufficient. But the practice, I think, is different. I agree with that. I mean, the most important is the patient's status, and he's active. He has no cardiac symptoms. Nobody showed that doing pre-cardiac workup for patient who's actively, you know,
and this will change your morbidity and mortality. I mean, if you do an angiogram, I'm sure you're going to have a lot of coronary disease, you know, but nobody showed that if you do pre-op like angioplasty or CABG bypass will decrease your mortality as far as patient is functioning. If patient is not has a poor function capacity is different, you know, or he has a history of MI, unstable angina, or something like that, then yes, you have to do a workup. But if patient doesn't have any cardiac history and his function capacity is great, nobody showed this pre-cardiac workup will change your outcome regarding morbidity and mortality. But in general, in our practice, we always do an echo. I don't think to change the outcome, just to get the anesthesia idea, how is the heart. That's what they always tell me. But in general, to change the outcome, I don't think it's any important. And this is our major argument with the anesthesia all the time. I'd like to hear from Issam what he thinks, because he's very active with this pre-op cardiac risk assessment, you know.
Yeah, no, I agree with Mohammed. I think if the patient's physical reserve is good and he's active, an ECG is adequate. You need to look at the ECG and see if there's any signs of ischemia on that. Echocardiography is only reserved for those with previous history of problems, valvular, or they have previous MI or something like that. And the only information it gives you is prognostic, is if this patient is going to have a MACE or major adverse cardiovascular event, are they likely to survive it? It won't tell you who's going to have the MACE. In the UK, we have introduced cardiopulmonary exercise testing as routine for all aortic aneurysm patients, where we put them on the bike and we measure their anaerobic threshold and their VO2 max. Now, there are many who would argue that that is probably the evidence for that could go either way. However, that is what we do. It's just another way of assessing exercise tolerance. So if somebody's playing 18 holes of golf, they're going to do very well on the bike. But if they're not that active and you want to get an idea, an anaerobic threshold of greater than 12, then you're fine. Between 10 and 12 is a moderate risk. Less than 8, you should probably be thinking about an EVAR as an option rather than open. But you know, we can discuss that. But for the purposes of this MCQ, I just think an ECG is adequate. But CPEX testing is also valuable in that respect. Stress echo is if you have a patient who gives you a history of angina and you want to see how bad it is.
So if you have a patient has a history of if you cardiac, I think the best test will be number D, right? The test is give you the best answer or evaluation of the heart. If your patient has a cardiac history. But this patient, I agree with Issam, with Muhammad. I think EKG is more than enough, you know. You want to add anything, or you agree with that?
No, I agree with you. We usually do echocardio for the EF of the patient with the heart. So, but in this patient, I think it's enough to do ECG.
So, Issam, let's say the ejection fraction less than 50. You think you need cardiac workup, or it is okay?
No, I mean, I think once you get below 35, then you have to question whether how well they'll tolerate the cross clamp. There's no need to do anything more unless you think they have reversible coronary artery ischemia. And that would merit at least cardiology review. They would then do a stress echo to see if there's any part of the myocardium that may benefit from revascularization. And then it gets more complex. But even then, if you revascularize prior, there's no evidence it improves mortality. It's yeah. But you may find somebody who's got a very critical cardiac lesion who needs treatment first to save their life before they have the aneurysm done.
That's true. Let me ask a question, Issam. One time I was reading that if you do a coronary angiogram in all vascular patients in general, 60% they'll have coronary artery disease. Is this correct number? It's too high.
That's too high. I mean, I think you have to make a distinction between occlusive arterial disease and aneurysmal arterial disease. If you have peripheral vascular disease or aortoiliac disease, so peripheral vascular disease, about half of them will have some degree of renovascular disease. About 25% of them would have coronary heart disease, and maybe 20% will have maybe carotid disease. But aneurysmal is far less. I think 60% across the board is way too high. If you took 70-year-olds and you did CT coronary angiograms, I think you'll find a big proportion of them will have irregular coronaries anyway. So, I mean, it's not necessarily symptomatic.
Yeah.
20 or 40% carotid artery concomitant occlusive disease or coronary disease, some.
40%?
They are about 40%.
For vascular disease or for aneurysm?
Coronary. Concomitant carotid artery disease concomitant with coronary artery disease.
Okay, carotid. Okay. Yeah. All right. We'll go to question number 5 so we don't waste time. Ahmed, you want to take this one?
Yes, please. If an option were being considered, which of the following factors are associated with an increased post-operative mortality?
Okay, let's talk about mortality.
Yes. The diameter being more than 60 millimeters.
Does that make a big aneurysm, is it increase your post-operative mortality?
And somebody who is stable, not ruptured? I don't think so.
Yeah, stable. I'm talking about stable. I'm talking about this. Yeah, in general, you're talking. Yeah. So diameter doesn't matter. If you have like aneurysm 4 centimeter or 10 or 20s, you know. I mean, the most important is the neck, really. But here, you not mention the neck. They mention about the aneurysm itself. So aneurysm itself is not a risk factor, correct?
Yes.
Let's go to B now.
Association with hypogastric aneurysm.
Okay.
Would make the approach different. Huh? Would make the approach different, but it wouldn't increase the mortality, would it?
Was it increase your time of surgery or not?
It might, yeah. Yeah, 12.
12, especially epigastric, it's hypogastric aneurysm. So anything increase your time of surgery, it will increase your operative mortality. I mean, if surgery takes 2 hours or takes 5 hours, you know. So I think indirectly, anything increase your operative time, it should, or complexity, not only the time, of course, the complexity. If you are slow or fast, doesn't matter. But hypogastric, bypass to the visceral, anything you do extra, I think you increase your mortality. So if you have a hypogastric artery aneurysm, and some of them are very difficult. Some he can tell you he had one a couple months ago, it was like a nightmare. So some hypogastric artery aneurysm could be really tough, you know. So then yes, you increase your mortality because increase your complexity of the surgery. So I think this will do that. Yes. Let's go to Steve.
How about those patients who are done in a staged approach? For example, the hypogastric would be embolized or as endovascular.
They're talking about the surgery. If patient has hypogastric aneurysm, I mean, they're talking. I mean, you see any question. Of course, you can the way how you look at it. You're right. I mean, if you do embolization different, then you're doing surgery, you're doing only aneurysm, it will not increase it. But if you decide to repair the hypogastric aneurysm and aortic aneurysm, I think this will increase your mortality.
All right.
Okay. Diabetes does rated with the mortality itself, patient diabetic or not?
No, it's not.
Okay. What about renal insufficiency?
Yes, it does.
Smoking.
Smoking, it does increase even pulmonary complication.
So not the smoking itself. Like, I mean, you don't think mortality unless if he has other problems, as I say, pulmonary dysfunctions, you know, then yes. But if his pulmonary function is normal, I don't think this will increase your mortality. See, so this question depends how you look at it, you know. But yes, mainly thing increase your mortality rate, the length of the surgery, renal failure. Of course, if you have a cardiac issue and pulmonary, you know, function test, I think this all increase your mortality. Also complexity of the surgery. If you're doing suprarenal, juxtarenal, or you know, surgery, it all increase your mortality. So I think this would be a good answer. What do you think, or Ali?
How's your food, sir? How is it going?
Good, thanks. Yeah, the worst prognostic factor for any vascular surgery is renal insufficiency. Correct. And that's something that we should not forget. I think we forget that very often. Smoking in itself does not increase mortality because most of these patients are smokers anyway. Diameter doesn't. But if you have to deal with the hypogastric, that'll push you. And diabetes per se does not increase mortality, neither an aneurysmal disease or, in fact, an infrainguinal reconstruction, surprisingly.
So you're right. So same answer. So mainly it's hypogastric and the renal insufficiency and the lung. If you have a COPD or lung problem, of course, you're going to increase your mortality. So lung function. But I agree. I think the two most important is the renal function and the complexity of the surgery. Increase your mortalities, you know. But renal is the most important. So when patient get renal failure after procedure, it's increase your mortality. So you have to be very careful with the renal when you do a surgery. All right, let's keep going. So we don't keep you here for a long time. Anybody want to answer or just go back to my fellows? Haytham, are you there? I see your name, Haytham.
Maytham in the OR. Zahra around.
Zahra? Okay, Muhammad, go take it. Maybe they are busy.
Yeah.
Muhammad, go ahead.
Okay, with the current information you get from the case report, what would you recommend to the patient, and which in case of higher operative risk?
So let's talk about two things. So this patient, what do you recommend for this patient, or what do you recommend if he this one not high risk, right? He's a normal risk because he has
normal risk.
So ask you two questions. First, if he like this patient, and second question, let's say if he has high risk, what other options? Okay. So let's say with this patient. So they want to what to do?
Okay.
Let's start one by one.
This is like a mild to moderate risk patient, fit.
Right.
Okay. And he's included in the criteria to repair. So he's not a candidate for duplex scan surveillance.
Because there's indication for surgery. So this is wrong.
Indication for surgery, yes.
Okay.
So he has there is
before you start, are you going to do an open or endovascular?
No, for this patient, I will start with open.
Why not endovascular?
He has aortoiliac aneurysm.
Okay.
That's very complicated to be treated like endovascular. He's a fit patient. So I'll give him the best surgery I can.
Which one is better? I mean, which one has less mortality, open or endovascular?
Depend on the early mortality or
early mortality.
Early mortality, the open has a higher.
Long-term mortality.
Long-term mortality, no, the open, the endovascular. I mean, in terms of re-stenting and re-intervention, it appears to be
about mortality. No, I'm not. I'm not talking about
mortality the same in the long run.
Okay, so they catch up, right? They catch up after
first
year of first early mortality. Of course, EVAR is better, less mortality, but they catch up later on. Yes. Why they catch up? Because most patients, they die from coronary artery disease, from the cardiac, you know, not from the rupture. So even if you less mortality now, but later on they're going to die from same disease, with coronary artery disease or cardiac, you know. Second thing, the ruptures also, it's increased the EVAR more ruptures than open. So yes. You save some mortality here, but you pay it later on, you know.
Yeah, for secondary intervention.
Which one has more intervention?
Yeah.
Which one has more re-intervention?
The EVAR.
EVAR, but now some people, they said if you start counting the hernia repair and everything, they may say the same, you know. But I don't agree with that. But some people, they argue even intervention is the same, right? Because you have to count the hernia repair and all the things, you know, with open repair. So, but in general, we can say both the same, you know. But this patient, not only because he's fit, look at the neck. You see when we did a CAT scan, his neck is very bad neck. So there's other reason why he's not a good candidate for EVAR, okay? Because his neck, you see conical neck and it's dilated, and you see it has a thrombus there. So it's not good for EVAR. So this one is good for open. So now the question comes, should we do an midline or retroperitoneal incision? Which one is better, we think?
Since the patient has no hostile abdomen and nothing, I think I'll do aorto bypass.
No, I'm saying in general, Mohammed, in general, you compare midline or retroperitoneal. Which one has less or complication, morbidity and mortality? Which one better?
I think midline, doctor. I'm not sure.
No, it's no different between both. Nobody showed that mortality is different, between midline and retroperitoneal, The only advantage of retroperitoneal is you have less pulmonary complications, This is the only thing, and less ileus. But now with the spinal anesthesia and everything, you can say are the same, The advantage of retroperitoneal than the midline is what? You have better exposure to what with the retroperitoneal incision? The suprarenal aorta.
Yeah.
Right? Because you go from the back. You see, when you go midline, you have a pancreas here, And so it's it's not very hard, but it's more difficult. So if anything you want to do suprarenals, is always retroperitoneal give you better exposure, for clamping and for exposure for, but of course, both are the same. Both same outcome. So which one do you feel more comfortable? But in general, anytime you want to go more suprarenal or you want to clamp suprarenal, always they think the retroperitoneal incision get a better exposure than midline, okay? The disadvantage of retroperitoneal incision is what? The right iliac, because it's too far from you, right? So if you have a right common iliac artery aneurysms, could be very difficult to get from retroperitoneal incision because it's very hard to get to the iliac bifurcation from the left side, retroperitoneal. It depends how patient is obese or not. Or if you have a hostile abdomen, you have a horseshoe kidney, then of course retroperitoneal is better. So each one has plus and minus, So you have to see what and how is what your comfort zone, which one you have more practice, which one you do better. So you have to look at all the things you decide. But I think both way, if you look at morbidity, mortality, I think both very similar. Okay. So you just have
how about the history of a hernia repair, inguinal hernia, that was done in the same patient? Would it affect your decision or not?
Not really. The second question is that should we do aorta by fem or by iliac? This is the main also question. I'm sure we'll hear different from Isam and Ali. So what do you think when you do aneurysms? Let's say the iliac are normal. Not normal, let's say you're going to, it's like half normal, like it's iliac aneurysm. And you want to do aorta by iliac. So you do aorta by iliac or by femoral, which one is better?
By iliac.
By iliac. Why not by femoral?
If the iliacs are normal,
it's
better to. If the iliacs are normal, and it's better to erode the hypogastric artery, the right hypogastric artery, I think in this case, because the left is aneurysmatic. So it's better to erode one of them, and at least. So I will go by iliac.
Okay, this is, again, the way and how you look at that, yes, you can do aorta by iliac. This is give you, it's easier. You don't have to go through a groin, and the problem is a groin. So people who advocate aorta by iliac, they think that you have less chance of complication because an infection, because you don't go through the groin. And we know the groin problem with lymphocyte, lymphatic drainage, infections, hematoma. Some people who advocate for aorta by femoral, I tell you, if you get a stenosis distal, which is not common but could happen, it's easier to be fixed with from the femoral when you have aorta by fem, because you can go there with a patch. Whereas aorta by iliac, you have to open the abdomen. But this is not true now these days because we can fix everything in the vascular now. Even aorta by iliac, you can go there and put a stent in the iliacs if you have a stenosis at the anastomosis. So again, as Isam said, you can pick up the way you want, but as far you are defense your approach. Okay. So let's go to this patient now, Muhammad. So what do you think? Let's go through the question. Oh,
so just before Mohammed speaks, Hamid, can I just
please.
Let's go back. Let's go back to the EVAR open, etc. I think, Mohammed, there are few areas in vascular surgery that at the moment as controversial a topic as this issue of open and EVAR.
Yes.
What you guys need to do is you need to make sure that you have read and memorized and absorbed all the relevant publications that have been out there so that you can deploy the arguments based on the best evidence.
Yes.
Yeah, so yes, early mortality is better for EVAR. What's the evidence for that? Well, we have EVAR 1, we have DREAM, we have OVER. Everybody agrees on that. The mortality catches up at 4 years, and then at 8 years, you start to see higher mortality with the EVAR groups. Overall mortality, you start to see higher cancer mortality, but you may not see aneurysm-related mortality being any different. But that seems to continue, and you need to know those papers inside out and be able to deploy your argument. The recent inclusion of incisional hernias for open is, people are trying to equate the reintervention rates. Now, an incisional hernia repair is quite a big operation. So, there are people who will die from incisional hernia repairs. So that's why they're being included, so that you get equipoise. However, most people who have an open aneurysm and develop an incisional hernia never come to incisional hernia repair. They live with it. So you need to really know that these papers, so you can deploy arguments and disagree, as you will hear Samer and I do so often, but based on evidence, and leave it to the judgment or the interpretation of the evidence. I don't know, does that make sense?
Yeah, sure, doctor, yeah.
Yeah, okay. And in terms of biiliac or bifemoral, as a general rule, an anatomical bypass is always better than an extra anatomical bypass. So if you can stay in the abdomen, that is always better for you than going to the groin, or for the patient, because of the long-term problems that Samer has said. But sometimes it is technically very difficult to stay in the abdomen, and it's much easier to go to the groins. So you have to have that pragmatism there and say, I would try to do biiliacs because of X, Y, Z. However, I recognize in a big, fat male pelvis that is narrow, that I can't do it. Okay?
Yeah. I
right.
think we had the same problem before with our iliac aneurysm, and we had to go to the groin. This patient is mildly obese and had iliac aneurysm. I prefer, and I think it's safer for me to go to the groin to do it there with femoral aorta bifem. I don't know.
That's an excellent answer. For me, as an examiner, I would say this surgeon is safe. He knows his limitations. Maybe when he's done 50, 60, he might be able to stay in the pelvis. If not, he's doing the safe thing. So that's the right approach. Yeah.
Yeah. Thank you.
Ali, what do you think about peritoneal and intra midline incision?
I have experience with the midline excision more than the retroperitoneal. If there is no any pulmonary risk factors, I think it's midline for me better, for me personally.
Yeah, I say it doesn't make a difference really. Nobody should make it, no questions. Yeah. Okay, but yeah, Muhammad, as Isam said, you need guys to read these trials, EVAR 1, DREAM, and OVER trial. You have to memorize them very well if you go to the exam, Very important. All right, there's not said. You can continue, Muhammad. So he underwent, they decided to do left peritoneal approach. Okay.
This patient underwent via left retroperitoneal approach and aorta right and left common iliac bypass with end-to-end anastomosis. The aortic anastomosis was performed just at the level of the renal artery with suprarenal clamping of 10 minutes. That was justified by the necessity of the suturing of the prosthesis on the healthiest segment of aorta as possible.
Okay.
Therefore, the retroperitoneal route gave better success to the suprarenal aorta. A cell saver was used and no heterogeneous blood had to be transfused. The patient post-operative course was uneventful and he was discharged on the 9th post-operative day.
Okay, that's good. So just give you what happened. I just want to add something before I forgot, guys. When we talk about the iliac aorta by iliac, we talk about common iliac. Never go to external iliac. External iliac is the worst artery to do anastomosis to it. So for some reason, if you can't do aorta by iliac at the common or at the bifurcation, then I think it's better to go to aorta bifem. But don't do anastomosis to external iliac. It's difficult, deep, And external iliac artery is like SFA. It's very bad artery. You get stenosis problem in the futures, okay? Just before I forgot this note. All right, let's go to question number 7. Ahmed, you want to take this one, Ahmed?
Yes, please.
Okay.
During an open operation for AAA, cell saver or transfusion can be used. Which of the following A's are incorrect? Are correct?
Okay.
It should be used systematically, meaning in all cases.
Yeah, this is correct.
Not really. If you can save it for the selective cases, it will be better.
So to become efficient, how much blood loss you need to become benefit from cell saver?
I'm not sure. I don't have a number.
Like usually at least 1 liter minimum to get really benefit from cell saver. I mean, less than 1 liter, it doesn't work. You can just give 1 liter of blood and you're done, you know. So to become cost effective, it has to be really more than 1 liter of blood, you know. So let's go to the next one.
So the answer B would make sense. It should be
Right.
reserved when expected blood loss is significant.
Correct.
And C, it should be substituted in all cases with the preoperatively deposited autologous blood transfusion. I don't see the relationship.
Yeah. Okay.
It presents fewer complications than unwashed cell autotransfusion.
Okay. You know what unwashed cell? I don't know if we do it here. Yeah, it less complication. Unwashed cell or autotransfusion, it gave you more complication. I think has less coagulation factor, less platelets. And the same for like, you know, if you take blood from outside, hypothermia is an issue. So yes, cell saver, I think it's the best. Yeah, less complications than unwashed cell autotransfusion. Yeah.
E, it should not be used in case of ruptured aneurysm. It
Correct
should not.
Yeah.
Generally, it is slower actually in suctioning, but you will get the blood back.
Yeah. Ruptured aneurysm, you have a huge loss of blood.
Yes, so you need faster.
Yeah, it's very important, ruptured aneurysm, because you have a lot of blood. You lose a lot of blood. It's not elective. Elective, you can argue about it because you can go, if the aneurysm is nice, you don't lose much blood. But ruptured aneurysm, you expect to lose a lot of blood. So you have to use it in ruptured aneurysm. This is the only place where it should really make a huge difference in the outcome with the ruptured aneurysms. So in ruptured aneurysm, you have to do cell saver. You can argue about straight, you know, forward small aneurysms, but anytime you expect to have significant blood loss, I think cell saver showed it improve your outcome. So it should be used. I know Ali or Isam want to add anything before the next question.
No.
Yeah, I use routinely cell saver in all open aortic aneurysm probably for the last 10 years before I came to Saudi. I've not used it in Saudi because the one we have to set up is a real problem.
Okay.
Now, I agree, Samer, that you probably don't need to use it for all elective aneurysms because you do need to bled at least 1 liter. And sometimes now it's unlikely you bleed 1 liter. However, if the team is not using the cell saver regularly, they become de-skilled. So one of the advantages of using it all the time is that they set it up very quickly, they get very slick, they use it all the time. And that's why my anesthetists always used to insist that we use it. Okay. The other thing is that in ruptured scenarios, I didn't like it, but I was forced to use it. And the reason for that is the sucker does not suck quick enough sometimes in a rupture for you to see. And the answer to that is to get 2 suction drains working at the same time, connected to the cell saver, because there's only a maximum speed at which the cell saver would suck, beyond which it destroys the RBCs. And we used to give autologous blood donation prior to use as well, if we're expecting a lot of bleeding. So we take a couple of units before the patient, from the patient, and also use the cell saver. So it's a really good thing to get involved in if you have access to it. And it is in the United Kingdom a part of the aneurysm quip routine recommendation for all open aneurysms that you should use a cell saver.
I agree with that. Ali, do you have it? Do you use it, guys? Do you have it, or is it expensive?
When I was in Italy last 19th, I think all our patients with AAA, we used to use the deposit autologous blood transfusions, 3 packs before the intervention, and we use the cell saver, yes, but here in Syria, no, I don't have it.
Yeah. All right. I'll go number 8. I think what that does genetic predisposition forever exist? Yes. Describe. I think guys, you need to read about it. So let's go to the last question, number 9. Hamad, you want to finish it?
Okay, doctor. A duplex scan has been performed to the patient brother, which found a 40 millimeter abdominal aneurysm. What is the recommendation would you give the patient brother?
So this has a small aneurysm.
Yeah, and small aneurysm. What do you recommend?
Do we recommend surgery for small aneurysms?
No. Below 5.5, no, but we put them in screening and surveillance.
So now the question, how often? And again, this should be an exam question. I'm sure they get this exam. So how often you do it for a patient with a 4 centimeter aneurysm? Do you do it every 3 months, 6 months, or every 1 year?
4 to 5, 1 year, isn't it, Dr. Samer? Every 3 years, from 3 to 4.
Sorry?
Every 3 years, from 3 to 3.9 centimeters. Then from 4 to 5, annually.
Annually, and then from 5 to 5.5.
Q3 months.
Q3 months.
Okay, that's correct. When become 5 to 0.5, it will be 3 months.
Yes, 3 months.
3 months. But if less than between 4.5 to 5, they recommend 6 months, and before that, every 12 months. You know.
Yeah. The answer is C.
Longer you get closer with you. But anything, I think at 4 centimeter once a year is enough. You know. Until it's like 4.5, then every 6 months, until like 5, then after that every 3 months.
Yes.
Schedule. So it could be more than one answer. You have to read them. Let me see. 3 months stable intervention with diameter. So what about
no, this is too much.
Too much.
And this is for repair.
Yeah.
What about they were talking about the 4 centimeter?
Yeah. Serial duplex studies at 6 months interval, and intervention if it reach or exceed 5 centimeter. No.
Okay.
Yeah.
We talk about C. What about
C? We talked about schedule the patient for surgery as he's smoker, and therefore his aneurysm will be most likely require intervention. I don't think so. This is a good answer.
Schedule for patient as he's no 4 centimeter? No, it doesn't. The risk factor doesn't give you what the trial. Do you know what the name of the trial? They look at the small aneurysm.
Yeah, they call it small aneurysm trial in UK.
UK small aneurysm trial. And they found that if the aneurysm less than 5.5, there's no benefit from repair.
Repair. And this is the study. They conclude the woman you have to treat at 5 centimeter because the risk of rupture is higher. So they change it. Yeah. But doctor, if the patient is extremely worried about his aneurysm and he's like 4.5, 4.3, is this indication for treatment? Because a lot of educated patients, like they are not very well educated, but they are educated enough that they know they might be ruptured. So they are asking to be treated while they are 4.3, 4.7. And we face like some patients like this. What is the best
answers?
Yeah, what to tell the patient? And we can tell them
the surgery and why is not. I mean, first you have to tell them that any size and aneurysm in any size can rupture. Aneurysm doesn't have to be 5.5 to rupture. I saw aneurysm 3 centimeters, they ruptures. Okay, so the first thing I tell the patient, look, the risk of rupture is there. Even is less than 5, even 4 could rupture. But the risk of rupture is less than risk of surgery because surgery has a risk. So this is what I tell them. I tell them, yes, there's a risk of rupture, but if you do a surgery, you take a more risk with mobility and mortality than if you just watch it. The reason why you have to watch it. And then they get convinced, you know. Some people, as they argue about EVAR, say, well, let's do EVAR for small aneurysms.
Yeah.
And Sam, he can correct me, or Ali, I don't think any data showed EVAR for small aneurysm is indicated. Even the data showed, even EVAR for small aneurysm is not indicated, because we thought, okay, this is small aneurysm, let's give him less invasive procedure, EVAR will work fine. But really, the data did not show that EVAR is indicated for small aneurysm. So still, 5.5 either for open or endo. We did not change, even with the technology improved, we have less mortality now. But again, short-term mortality is still, indication is still the same, 5.5 even for EVAR. I'd like to hear Isam and Ali.
Maybe I'll go before Ali. The UK. Sorry, تفضل علي تفضل.
عفوا تفضل عسام.
The UK small aneurysms trial that came out of Charing Cross was the coordinating center, showed that 5.5 centimeters was the size at which the benefit of intervention outweighed the benefit of serial surveillance. Now, there's an important point here. The UK small aneurysms trial was using ultrasound as the modality for measurement in the AP diameter. And many people don't know, especially as they're training, that if you take the same aneurysm and you scan it with ultrasound and then you do a CT, the CT will tend to almost always give you a slightly bigger size by 2 or 3 millimeters. So that's something to keep in mind when you are thinking about, do I intervene at 5.5 on CT? 5.5 on CT will be around 5.3 on ultrasound. So the evidence was around ultrasound, which at that time we were using, but now everybody's using CT. More interestingly, and this is something that maybe you can read up on, with COVID and everybody stopping vascular surgery for a year, worldwide, we have not seen an increase in the incidence of ruptured aortic aneurysms and deaths from ruptured aortic aneurysms. And Michael Jacobs presented some of the European data, and people are saying, you know what, maybe 5.5 is actually too early as well, and we should be talking about 6. But that is not science, but that's something that you need to just think about and read up more on. There is no indication, Mohammed, to intervene in somebody with a 4.3 centimeter fusiform abdominal aortic aneurysm. And you must try your best to dissuade the patient. If the patient insists on treatment, make sure that it's somebody else who makes that mistake and not yourself.
Okay, sure.
What about EVAR, Isam? Do you think that EVAR should give us, less threshold to treat aneurysm because less morbidity, mortality?
No, you're just increasing what people would call the lead time, because the evidence is that the longer they live, the more interventions they will need, and at 8-10 years they're going to run into problems. So there's no evidence, EVAR, open, whatever, that there's a role in most patients at 4.3. Now, I do agree in women, you might, if it was a woman, I might consider it if it's under 5. And she's very worried, and because women do rupture at a smaller size. It's accepted now, and there's pretty strong evidence for that.
The second thing is that, I know you can correct me also, Isam, that when we talk about the size, always we talk about AP size, right?
Absolutely. Absolutely.
Yeah, so you have to be careful, guys. When you measure it, sometimes I see people measure oblique, right, left. All this study done in AP size, size measuring. So it's very important.
Yeah, and the answer why it's the AP is not because the transverse is not important, but it's because the AP diameter is the most reproducible measurement between people, so it is more accurate. Yeah.
All right, Ali, you want to say anything before we close?
I agree with Isam. We treat patients basing on the guidelines, not on the will of the patient. If he wants to be treated, so he can search another one. These patients or these cases, we face them when we have claudication, lower limb claudication. Some surgeons tend to operate stage 2B, 2A, for example, and not the critical limb ischemia or distances less than 50 meters, as we do now. So I think we have to follow the guidelines and not the will of the patient or what the patient wants in these cases. And this is for the fellows who will face these problems later during their activity.
Okay. Thank you, Ali. Thank you, Isam. Sorry, I kept you a bit longer than we expected.
I have only one question, Professor.
Yes, please, go ahead.
Hi, it's Hazem.
Hey, Hazem, hello.
Hi, I have one question. Here we are talking about his brother. So there could be somehow a hereditary disease, because here we have a slightly small, I think the indication should be slightly smaller than in normal patients.
I mean, when you look at the risk factor for rupture, inheritary was not one of them. That you have connective tissue disease is different, you know.
Yeah.
This was a question about inheritary. I just skip it, you know. But having like family history, I don't think it's increased your chance of ruptures, you know. So I still think you have to follow the same guidelines. This is my information. I know if Ali or Isam different opinion, or you have a different opinion. You have any different data? I don't know. You can tell us if you have anything different.
Actually, in Germany, we are using also the German guidelines.
Okay.
And German guidelines, according the hereditary, we are going to operate the patients up 5 centimeters.
Yes, you mean family history? You mean it says family history
Yes.
Okay. Okay, I think we need to look at it. I think for me, I don't know. I know for Isam or Ali, we can look at it and see. Do you have any data you can share with us on the discussion group? It would be nice if you have any paper or something like that, discuss with us. Just put it in the group so we can look at it.
Thank you, sir.
Thank you. Thank you, Hassan. All right, thank you, guys. We'll see you. We want to do every week or every 2 weeks? I don't know. It's up to you guys. But this is the way every time we bring a scenario. Next time we're going to talk about endovascular repair of aortic aneurysm. This case was open. So next case we discuss EVAR. Case of EVAR. I put the case on the group so you can prepare for it. And then we'll see, guys. We can go next week or week after. It's up to you. But thank you very much, and appreciate all the consultants with us. And we'll see you soon. Take care.
Thank you.
Thank you so much.
Thank you so much.